Today we have a great pleasure to talk to Stephen Faraone, who is a distinguished professor in psychiatry and neuroscience physiology at the Norton College of Medicine in Syracuse, New York, and a lecturer at Harvard Medical School. He is also program director for the educational websites ADHDinadults.com and ADHDevidence.org, and president of the World Federation for ADHD. And now, get this, he is ranked 80th best scientist in the world. That's like incredible. Congratulations. And I know how much work that demanded from you. So that's an achievement. That's an achievement. And of course, we will be talking about ADHD because this is the main topic of my YouTube channel. And this is also what we both work on. I propose to talk about a few of the recent papers that were published in the field of ADHD, which, in my opinion, some of them are even breakthrough papers, like the one on genetics of ADHD. Some are very important, and they somehow at least broaden our knowledge on different side effects of medication, let's say. So let's start with the first paper from Nature that was published 2 years ago in February 2023. And this is the paper on the genetics of ADHD. For many years, it's been difficult for us to talk to the patients and explain to them why it happens that so many members of the family, if one of the members in the family have ADHD, why so many of the others also usually have ADHD. And we know about recessive and dominant genes, but even in dominant, if the gene is dominant, it's only 50% of the disease or disorder to be genetic. And in this case, we see that it's rather more, 70 or 80%, as your studies also show. So, in my opinion, this was a very important paper showing that there are around 7,000 gene variants that participate in the predisposition to ADHD. What do you think in practical terms? What does it tell us that 7,000 gene variants predispose to ADHD?
So I'm going to back up a little bit to go into a little bit of history for the audience, because I think it's important to understand where we came from and where we're at. So back, let's say, early 1990s, when I began studying genetics of ADHD, we had no data about DNA, but we had a lot of data on ADHD in families and in twins. And those studies told us that ADHD was a highly heritable condition, about 70-75% heritable. Which roughly means that in the population, about 75% of ADHD can be explained by underlying genetics. And that was very compelling and led us to do these molecular studies. The molecular studies, we fast forward now to the 21st century. Essentially, I had the real pleasure of leading an international consortium to collect a huge sample, over 100,000 people, the biggest experiment ever in ADHD. And that's the paper you're talking about. And what that paper showed, which is really very interesting, because back in the 90s, we were hoping maybe there was one or two genes that were causing ADHD, and that those genes would point to a certain protein in the brain, and that protein would point us to a way to fix ADHD with some kind of medication, perhaps. It's not the case, because as you said, the current data suggests there are about 7,000 variants. Now, when I say 7,000 variants, what does that mean? That means that first of all, we're talking about most cases of ADHD. I have to mention that there are a small number of cases of ADHD are probably due to what we call rare genetic variants. These might occur in 1 in 10,000 people, 1 in 5,000 people. And there was a new study led by Dr. DeMontis as well, which has documented some of the rare variants. But for most people, they have what we call common variant ADHD. And that means that the variants, which are segments of DNA, they occur in many people. They might occur in 20% of people, 30% of people. They're not unusual. Now, the 7,000 people have to understand, this is a kind of a a result of kind of mathematical modeling, that we know there are 7,000 variants. We don't know exactly what they are yet. We know for sure about 27 of those variants. We know we have 27 segments of DNA that we know are very strongly associated with ADHD. And those have been the focus of interest for obvious reasons, because they help us understand the biology of the disorder. But because there are so many, we call ADHD a polygenic disorder. Polygenic just means many, 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 many genes combined. We don't know how many of those 7,000 people need. They might need 100, they might need 200. Maybe they have 100 and they have some kind of environmental issue that kicks them over the threshold. But the data are extremely, you ask why are they important? They're important because it's also consistent with what we know about the variation of ADHD symptoms in the population. I can give you a comparison. If you were to look at, let's say we take the case of intellectual disability, people who have very low intelligence scores and lots of difficulty functioning in the world. If we look at intelligence scores, what we see is two distributions. We see I'll just kind of draw like a normal distribution of almost everybody in the population. And then at the very low end, very far away, there are these intellectually disabled people. They're a very distinct and separate group. In contrast, when we look at ADHD symptoms, we don't see a separate group. We see people have lots of symptoms, people have a moderate amount of symptoms, people have few symptoms, but there's no distinct cutting point like there is for intellectual disability. And so that tells us that ADHD is kind of more like a trait in the population, more like let's say personality, other kinds of traits that everybody has a little bit of. And when we think of ADHD as a disorder or as a problem, so it's very much like hypertension. Everybody has a blood pressure, but some people have a very high blood pressure. Everybody has a cholesterol level. For some people, cholesterol is too high. So it's extremely important because that we can, if you want to talk about more about this later, that it means that there's a cutting point, if you will, where doctors have to separate who has ADHD and who has not. And that's where a lot of the debate occurs about, is ADHD overdiagnosed or underdiagnosed?
Yeah, we will probably return to that. I wanted to ask about another thing, though. The same study shows that lots of those variants, 80-90%, are shared between ADHD and other psychiatric disorders. And that is, once again, very important and very interesting, because one could ask a question: is it ADHD causing those variants, or are those two separate entities, like ADHD and depression, or ADHD and anxiety disorders? Many patients ask that. Is it two separate things, or is it actually the same? What would you say?
Yes, great question. It's a great question. And again, to give the audience a historical perspective, I think which is important. You go back to the 1990s, late 1980s. In psychiatry, we were taught, or in psychology, I'm a psychologist, but when we were talked about psychiatric disorders, we were taught they were separate and very distinct. Autism was different from ADHD. You couldn't say someone with autism had ADHD, for example. That's a classic example. In the 1980s, nobody diagnosed depression and ADHD together. It was one or the other. And then me and a bunch of group of colleagues at Harvard, where I was at the time, we did a bunch of studies which documented high levels of comorbidity. And then other groups also did this as well around the world. And so we found that in the clinic, it was very common for someone with ADHD to have a second disorder or a third disorder. And gradually, the diagnostic manuals dropped this idea that disorders had to be separate, and we knew this comorbidity occurred. Now we go to the 21st century, and we're finding that this comorbidity, meaning people having more than one disorder, is explained in part by shared genes. In a very new paper, in fact, this one's coming out, I think this is actually in Nature, like one of the highest journals in science, coming out roughly in mid-December. A very big group of us in the Psychiatric Genomics Consortium, led by a very talented young man called Andrew Grotzinger, are publishing a paper which starts to lay out what we call the genomic architecture of psychopathology across many, many disorders. And what we're finding is that we first identify that there is a common set of calling them genes, but they're actually genomic variants. So I have to stop and explain to the audience when I use the term gene because we're studying DNA, but actually sometimes the segment of DNA doesn't actually contain a gene.
Parts of genes.
It contains, well, more importantly, it also may contain no gene at all, but contain what we call a regulatory region, which is a part of the genome that regulates DNA. Another part of the genome. That's also very important because some of those regulatory regions can be modulated by environmental factors as well. But when I say genes, I mean very broadly genomic regions that are
parts of DNA.
In the parts of DNA, right? So we know that there's a set of genomic regions that are involved in. Well, I should actually talk about the disorders. The disorders this group studied would be bipolar disorder, schizophrenia, depression, anxiety disorders, ADHD, autism, Tourette syndrome, and several substance use disorders. And what we found was that there's a set of genes that is involved in all of these disorders. These are very common, I call them cross-disorder genes, cross-disorder variants. Then there are several separate families, if you will, of disorders that tend to share more genes than the others. So, for example, there's a group of neurodevelopmental, we call them neurodevelopmental disorders. ADHD and autism share a lot of their genomic overlap. So do schizophrenia and bipolar. That's actually the strongest genomic overlap we have. So do anxiety and depression, and so do substance use disorders. So there's like separate groups that come out. Now, ADHD also shows some sharing with substance use disorders, which won't surprise a psychiatrist, and also with Tourette syndrome. Now, you're nodding your head because as a psychiatrist, you know these genomic groups make a lot of sense from a clinician's point of view. They're exactly what you see going together in the clinic.
Yeah. When we talk about those gene variants, you said that, I will just say it, the associations are not very strong, right? I often say to the patients, it's a cloud of genes, meaning that it's not so well defined. This is what I mean by saying it's a cloud of genes. So if it's like that, what does it help us to, let's say, look for ADHD in the genes? Or so, in other words, should we do DNA testing, for example, to say whether someone, probably not whether he or she has ADHD, but maybe is really predisposed to ADHD? Is it possible at all?
So I hope that someday that will be possible. It's currently not possible. And that has to do with the precision we have in knowing exactly which variants are involved. We don't know exactly which ones yet. And that has to do with, it's really very simple, actually. It has to do with sample size, the number of people we have in our genomic sample. If we were to have 1 million, we'd probably have a more precise risk score. We currently can compute a risk score. We call it the polygenic risk score. Everybody has one. I can take, your DNA. I can say your risk for ADHD is at a certain number, but it doesn't do it. It's the risk score. The polygenic risk is, of course, greater in people with ADHD than without ADHD, but it's not accurate enough to make a diagnosis.
Yeah, so we cannot be sure whether somebody has ADHD because we tested.
Exactly. And we can't use the risk score to diagnose ADHD. We can't use it to say which medication they'll respond to. This is the future of research. We're moving in that direction, but I do think it might take decades to actually get there.
That's actually very important from the clinical point of view, because we see that all the patients are different. All the patients with ADHD are different. And we should, I always repeat that we should always individualize our treatment. And we have those different tools. We will talk about that based on the Lancet publication about the efficacy of different treatment modalities later on, but we should offer different treatments to different people with ADHD, and that's probably like some groundwork for that for the future.
Right. That's right.
So genetics of ADHD, like I said, is very important. Also, from the point of view of explaining ADHD, not only for the diagnosis of ADHD, but also for explaining what ADHD might result from or originate from. And let's now go to the second paper that we will review today, Genomic Analysis of the Natural History of ADHD. Uh, so there's this theory that theory, I think it's true, but okay, let's call it theory, mismatch theory, that for many, many ages, humans developed and their development was adjusted to environmental changes. And only now, for the last several thousand years, our development is so fast that the changes in our DNA do not catch up, and that there's a mismatch between what we are made of genetically and the environment. So this is called, for our audience, this is called mismatch hypothesis. And what do you think in the context of ADHD? So let me first ask you in general, what do you think? Because there are some patients who say, ADHD is just a genetic predisposition or genetic difference. It doesn't necessarily mean that I have to be treated. I mean, when I said, let me make a disclaimer. When I said treated, I do not mean medication. Okay. So I mean, these different modalities that we have in ADHD,
yes,
right?
sure.
Because we should always remember that there are different solutions for different people with ADHD.
That's right.
So those people say that I should not be treated because I'm simply a different human being. Well, okay. So before I say anything else, what do you think about that?
Okay, so yeah, what you're talking about is something that derives from what we can very broadly call the neurodiversity movement, which is a popular movement in the community of people with ADHD and autism, but it's also something that's been promoted by many professionals and even philosophers that think about mental disorders. Well, the way I would respond to somebody who says that, I would say, number one, I would say, you are an autonomous individual, and you certainly have the right to decide what kind of treatment you want or don't want. There's no question about that. No one's telling you have to be treated. So number one, that's number one. Number two, no, if somebody with high blood pressure came in and said, I'm just different, I don't need to be treated, I would say the same thing. You're an autonomous individual, but you could eventually have a heart attack or something because of your high blood pressure. It's actually kind of dangerous. And I would say to a person with ADHD, there are risks associated with ADHD that you need to consider when you balance these things out. Now, what's unfortunately happened with the people to understand that the neurodiversity movement is not a scientific, or neurodiversity theory, as it's sometimes called, is not a scientific theory. It's a philosophical theory and a political theory, and it has to do with what we do in the political system of the societies we live in, and should society adapt better to ADHD and autism? That's a political question, not a scientific question. I understand, it's not unreasonable for someone to say we should adjust society so that the lives of people with neurodevelopmental disorders are better. Absolutely. I think we should teach children at a very early age to understand these disorders so they don't stigmatize, alienate, and cause more problems for people with ADHD and autism. And that would do a lot to help these folks. Absolutely. But please, I think, audience, understand that this neurodiversity theory is not a scientific theory. It's not telling us anything different about the science of ADHD than what I can tell you or what another scientist can tell you. It's more a discussion of how society should adapt or not to people with these disorders.
I would say that it's an answer, what you call the movement, what you rightly call the movement. I would say that it's a response to invalidation by the society of people with ADHD. So they look for validation, and that's probably why they call or formed this explanation. But actually, I say nearly exact things. What you just said. That of course that's a decision of an individual whether she wants to be treated. But usually ADHD is associated with several or some at least negative outcomes, and one should remember about this. So exactly the same thing. So let's return to the paper. And this paper evaluated the frequency of those genes associated with ADHD in the sample of many. I don't remember how many, but many.
It's probably over 100,000. It's huge.
Yeah, something like that.
No, sorry. You're talking
20,000. Yeah, the paper
about a different study. Yeah,
Yeah.
you're talking about the ancient genes. Yeah. Yes, I'm sorry.
Yeah, it was, but still 20,000 individuals diagnosed with ADHD.
Yes.
So these were early humans, let's call them, from 30,000 years ago, and then 2010 and 5,000. Yes. And this study shows that the frequency of ADHD genes decreases with time. What do you think? Right. What in your opinion, what does it tell us about?
Okay, so let me just explain to the audience how we know how we have genes from people from 30,000 years ago, and that's because some very smart scientists figured out how to extract DNA from bones from Paleolithic, Neolithic samples. It's wonderful. So we call this ancient DNA that can be analyzed, and we can know what somebody's ADHD risk was back 30,000 years ago. And what this group showed, actually, I was part of this paper of a group from Barcelona, led by the Barcelona group that studies ADHD. Exactly what you said, that the variants that we believe cause ADHD have been decreasing over time with frequency. So that's what we call the empirical finding. That's the data. Now, the interpretation one can make of that is one thing is very clear. When a gene or a piece of DNA is being eliminated from the population, it means it's not very useful in the population. It's that what you call mismatch, that our genome doesn't match what the environment needs, and so those people are less likely to survive, reproduce, and pass on their genes. And so my interpretation is that ADHD usually was not good for people in ancient environments. Some people argue that maybe it was good at some point in time. We really can't say that it was. We have no way of knowing that, because the question is, well, why do those variants even exist? Well, it's possible that the variants exist because they might have done something else that was helpful, not ADHD, but something else that might have been helpful because there were so many of them, and maybe say 100 of them were very useful for some other purpose. But what's really important for people to understand is that ADHD, as far as we can tell, going back 30,000 years, was never really an adaptive trait. It wasn't. I mean, some people do argue, oh, maybe if you had ADHD, you were inattentive, somehow you were more creative, and that helped you out there. But that's all speculation. Because I can also say, if 30,000 years ago I'm out in the savannas of Africa hunting a lion, I really shouldn't be inattentive. That's not going to be very useful for me. But again, that's all speculation. But what's hard science is that those genes have been disappearing from the population. Now, someone might say, well, how come they're still here? How come we still have 7,000 variants? And the answer is a complex one that's kind of mathematical, which I honestly don't completely understand. And that is, people who are experts in genetic epidemiology will tell you that when you have a disorder like ADHD that's highly polygenic, it takes a very, very long time, if ever, for those genes to disappear from the population. In addition to that, one of the things we know about the ADHD, geneticists call it the phenotype, meaning those are the behavioral manifestations of ADHD, is that people with ADHD are actually more likely to have early sexual activity and even more children early in life. And so there's this other counterbalance to the maladaptive aspects of the genes, is that they literally are probably helping people reproduce more and pass those genes on. So that's one reason why it stays in the population.
Yeah, Like you said, there are several mismatch theories explaining. Actually, this is all I'm talking to the audience because you, Steve, know that. So there are several mismatch theories showing or saying, sorry, not showing, because these are only theories, that those ADHD-associated behaviors could have been adaptive 30 or 40,000 years ago. For example, when someone was a hunter, and maybe the fact that he made fast decisions or that he was impulsive, maybe it helped him. But like Steve says, it's only a theory. We don't know that. And well, this is kind of still looking, I would say, you said mathematical problem, but I would say it's philosophical problem, because still these are all theories. We don't really know, and still, I mean, at least me, I can't, I know that there are many negative side effects of having an ADHD, having ADHD. So I would still say that it's a disorder, because some people might say this is primal behavior that I have from my ancestors, and this is a variation of norm, of standard, of normal human beings. And once again, this is not a disorder. And what? Yeah.
And again, that brings us back to where we were with neurodiversity. So it is true,
Yeah.
as we said before, that ADHD it's a variation of normal behavior. We know that from the genetic studies. We know that from the population studies for symptoms. But again, it's no different from hypertension or other disorders that are, if you will, continuous or dimensional traits in the population.
Yeah. It's funny that
you also importantly,
yeah.
I should mention that one of the important points of the genomic study is that these ADHD variants have been around for a long time, and they've been maladaptive. So we know that ADHD is not new, that back 25, 30,000 years ago, somebody had ADHD and it harmed them. It argues against the idea, which you hear a lot, ADHD is just caused by modern environments. And I've been in this business for 35 years or more. And ADHD was once, people thought it was caused by television, it's caused by cell phones, it's caused by tablets, it's caused by AI. I mean, people always say the new technology causes ADHD. When I say, number one, the genes have been around for a long time causing problems. The epidemiology study shows that the rate in the population has been constant over time. So it's just not true. And fun fact, when was the first, when do you think, well, ask the audience, when do you think, audience, the first description of ADHD occurred in a medical or psychological writings?
They know. I talk a lot about that.
Oh, you told me the history. Okay.
Yeah, 1775.
Very good. Well, good for you, Jarek. Very good. Yes, it goes back to 1775. It started, by the way, in Europe. It started in Scotland and Germany, where the first descriptions were. It wasn't, as some people say, an American disorder that somehow the Europeans adopted it. Actually, I call it a European import to America.
Thank you very much for turning our attention to that. That's a very important point about this study. And I also use this study sometimes talking to patients, for example, parents of a child with ADHD who say that maybe it's just because he's playing his console too much or something else. And I tell them that it's actually the risk of ADHD decreases in the span of those tens of thousands of years. Let's go to the third paper, and this one is connected with one, maybe even the most important side effect of medication, or one of the greatest dangers of stimulants, which is increasing cardiovascular risk. So we know that our medication increases heart rate and increases blood pressure, although this effect is modest at most, I would say. And there is a paper I think it's quite new. It's from, 2024. And it's called Attention Deficit Hyperactivity Disorder Medications and Long-Term Risk of Cardiovascular Diseases. And it says that in people who use ADHD medication for more than 5 years, this fact is associated with 23% increased risk in cardiovascular disease. Let me ask you first. I kind of know that you will not probably be able to answer that, but do you think this is a cause and effect relationship, or is it just association?
You're asking the right question. I think I think the audience should have some background. I'll give them some background about this. The first, you already gave some background, of course, about the known cardiovascular risks. It's very important that people with ADHD are screened for pre-existing cardiac abnormalities, because the drugs that are used for ADHD should not be used with somebody who has pre-existing abnormalities. We know that for sure. Number two, there have been, the paper you mentioned, there have been papers like this published over the last 20 years, where somebody does a big study and they find an association. When regulatory agencies have examined those, like the U.S. Food and Drug Administration or the European Medicines Agency, they've consistently concluded that there's no increased cardiovascular risk, that those studies did not mean medication should be removed from the market. The only case I know that disagreed with that was, this might have been 20 years ago, the Canadian regulatory agency decided to remove Adderall, which is an amphetamine, from the market because a paper came out about cardiovascular risk. There was a big uproar in Canada about this because the FDA didn't withdraw it. And
when was it, Steve?
I'm saying it's 15, 20 years ago. It was a long time ago. And eventually the Canadians changed their mind because the data weren't strong enough. They weren't. Now, what people have to understand is that, for example, take the paper by Zhang et al., which concludes increased cardiovascular risk. Well, we have to be careful when we throw around terms like cardiovascular risk, because when you look at their data, the only increased risk was for hypertension and something called peripheral artery disease.
Yeah.
Those are the only increased risks. Now, they looked at many, many, many types of problems, and there's this problem we have with what we call multiple comparisons. You look at many, many things, something might come out just by chance alone. Now, I know from the way that regulatory agencies think, they do worry still about problems that occur like this. They think about it. They spend a lot of time. The FDA itself does what they call post-marketing surveillance, where they look at reports that come in about people who have had severe problems on medications, and then occasionally they change their idea about a medication. So they might, for example, based on some data, I think that were developed after atomoxetine was put on the market, they added what they call a black box, that there was a small risk for suicidality with atomoxetine, as one example. They haven't done that with cardiovascular risk yet because the data have been, again, in people without pre-existing conditions, because the data haven't been strong enough. So going back to the Zhang paper, so the only increase is for this peripheral artery disease. And I looked it up. It's relatively rare. It occurs in about 0.5% of the population, roughly speaking. So a 23% increase in risk means that the risk for a person with ADHD is still below 1%. Again, so if it's true, right? Let's say if it's true, and it might be a mistake, right? Not because the researcher did anything wrong. This is a very solid research group, I should have mentioned. These people know how to do this work. Everything they reported, we can rely on. But still, it's an association that it might not be true because of potential confounds that they couldn't adjust for, or because they've looked at so many things. Now, 23% increased risk means, a person with ADHD, let's say if it's true, your risk is less than 1%. You balance that off with other risks associated with ADHD. If you're an adult, maybe that means an automobile accident. We do know there's a small increased risk for premature death due to accidents and suicidality. So it's that's where the discussion with the patient's clinician is important, to say, what are my increased risks? What are the adverse events? And what are the other risks of not treatment? And my experience is that people tend not to think about the risks of not being treated. You just don't think about that. It's very interesting. It's a human psychology, I think, that if we don't do anything, we don't feel like we've created a risk because we've always had that risk. If we do something new, like take a medicine, we really feel like we're increasing our risk. But guess what? You're also increasing the risk by not doing something. Well, I'll take that back. You're not actually increasing the risk because you have that increased risk, but you're not reducing the risk when you can. And people have to think about that balance. And it's very difficult. I mean, you have to do that with any medicine we take, ADHD medicine or medicine for anything else. That's
some time ago, I recorded a conversation with Sam Chang from Canada, and I asked him, "What do you tell parents of children with ADHD when they ask you, will my child not get dependent on methylphenidate, let's say?" And he said, first of all, they have to remember that a child with ADHD has, unfortunately, very high risk of being addicted to something without medication. And when the child gets started on the medication, the risk falls, that depends on the studies, from 30 to 50%. So that's what you said, right? So we always, and in clinical work, like I consult patients many hours each day, and this happens 90% of time, that patients only ask, let's say, if we talk about cardiology, will this medication increase maybe a few millimeters of my blood pressure? And I say, but do you remember about other risks, that the ones that you have when you do not get treated? And that's what you said.
That's right.
That's incredible.
That's right. I'll also make another point about the peripheral artery disease finding, is that because I did look into this, that peripheral artery disease risk increases with hypertension. And so it's conceivable that what happened in Sweden, where the study was done, is that some patients developed hypertension. It wasn't noted by the clinician, and the hypertension led to PAD, peripheral artery disease. So that might indicate a problem in the healthcare system, not a problem with the medicine. Because as you know, a physician monitors hypertension. It's easy to control hypertension if it occurs.
Yeah, there's another argument, because the paper says that the risk was highest or grew, especially during the first few, 3 to 5 years of medication administration, and then it's stabilized. So if it's connected with the medication, shouldn't it continue increasing with time?
Yes, one would think it would continue to increase in time. Yes, I agree with you there. That's it's part of, and that's part of what one looks at when you're looking at a study like this. You have to look at those kinds of details to really understand the effect.
Yeah. Let's go on to the first study.
I think that said, the audience has to understand that there's always, any medicine you take, any medical procedure or medicine you take has the potential risk for rare events that are even unknown, and you always have to balance that out by what the what that. I don't take that lightly. I don't want people to think that somehow I'm ignoring, I'm taking lightly the risk for medications. I'm not. In fact, I have a son who's been treated with stimulants for decades, and I think I realized that there's potentially some risk, even though I don't think that's a real risk. In the back of my mind, I know that's potential, but I have to balance things out.
Yeah, that's another thing that I repeat many times, that I say that everything in our life has pluses and minuses, advantages and disadvantages. Everything. Going to the university has some advantages and negatives, of course.
Exactly.
And we always have to weigh which one is better, whether getting a good education is better for me in the future, or maybe not spending money for going to the university, right? So it's the same with the medication. We always have to balance those things.
That's right.
Let's go to the fourth publication. It's called Methylphenidate and Short-Term Cardiovascular Risk. This one says that in people who are taking methylphenidate, specifically methylphenidate, because the previous study was talking about all kinds of pharmacological treatment of ADHD. And this one is only talking about methylphenidate. And during the treatment, so they measured cardiovascular events. Was it 6 months or 12 months before the treatment, and several months after the administration of the treatment? And they found that getting treated with methylphenidate increases the probability or the risk, in fact, of cardiovascular events. But interestingly, the study did not find increased risk in those patients who had prior cardiovascular problems. So one should think, or at least I would think, that if someone has pre-existing cardiovascular problem, starting the medication
Yes.
would increase the risk, right?
That's
And
right.
if it doesn't matter whether you have some cardiovascular problem or not, you still have increased risk. That's kind of strange. How do you comment on that?
I totally agree with you. And that's exactly how one should look at these kinds of data. They have to make sense. They have to make sense. It's not just, you can't isolate the finding from the broader context. Another thing I look at when I look at that paper, I think, well, this paper, for some reason, doesn't talk about hypertension or peripheral artery disease. And they have a list of risks in the same population that's different from the other paper. And that's a little strange. It's like, well, why not put this all together so we can understand it? But to say you found this over this, it just seems a little bit to me, what's the word for it? A disorganized way of looking at this problem. I think that I know these people, and again, they're good scientists, and I intend to talk to them about it. They really should do a very thorough examination of this issue in one publication, not separate them out like this.
I'm looking was it the same? Yeah, it's the same group, right? Both studies are done.
It's in the same group. It's all in Sweden. Yeah. It's all done. It's all Sweden data. Again, very solid group. I know some of the authors. They're top people in the field. But the audience has to understand that these big population studies are very impressive because they have big numbers, and they produce a lot of very interesting and useful data. But we also have to understand that they are subject to something called a confound. When we do a clinical trial, right, we have what's called it's an experiment. We randomize patients to treatments, and we know that if someone improves in treatment, it's because of the treatment and nothing else, because we've controlled the experiment. An observational study is you're looking at people over time, which is useful, but what it also means that you can't control for things that might differ. So you might be comparing ADHD people on stimulants versus not, but they might differ in other ways. For example, people who take medication sometimes are more severe. They have more severe ADHD. And we know that if you have more severe ADHD, you certainly have more psychiatric comorbidity. Maybe you have more cardiovascular comorbidity. So we have to be careful about those kinds of confounds. And in fact, we do know, and people have to keep this in mind, that ADHD itself is a risk factor for subsequent cardiac events independent of medication. In fact, there's a whole big study. It's actually led by the Swedish group, Henrik Larsson in Karolinska. Excuse me, Henrik Larsson. We do know, I know this because I'm part of the study. I have my group in Syracuse, New York is part of this work. And we do know that ADHD itself carries a risk for cardiovascular risk. We do know the ADHD itself carries a risk for cardiovascular outcomes. And so that may possibly be confounding this association. It's difficult to know.
Yeah. That's very interesting. When I was listening to you, I remembered one thing. Often when I present different studies, when I give lectures about ADHD, I say that sometimes, in this case, both studies are from the same group, so this is not the case. But in general, ADHD gets very differently diagnosed all over the world and very differently treated all over the world. And in my opinion, you should be very careful comparing Swedish and American or Polish or Czech study on ADHD, because for lots of different reasons, the diagnosis may be done completely differently. And like you said, the group of people who get diagnosed with ADHD may be completely different. And that, in my opinion, strongly affects the results. Do you think
Well,
so?
so what I would say is I would disagree only in the sense I wouldn't say that the diagnostic practices are dramatically different and that the groups are dramatically different, but there are differences. There are differences that one has to be aware of. So, for example, the Swedish studies are based on what they call medical register data. They're just using diagnoses that are recorded in the medical register, and they vary dramatically because different physicians in Sweden may have different ideas about ADHD. Some may only diagnose very severe cases. Some might have a broader diagnosis. There have been data coming out of Taiwan and Hong Kong also using medical registers. The cultures there are very different, and how ADHD is treated in those societies is very different. And so you're right, that will lead to a different mix of patients. There'll be an overlap. Some of them will be very similar, but those differences in culture, differences in diagnostic practice are very important. Plus, differences in treatment are dramatic. I mean, some medicines that we have in the U.S. are not available in Europe or Taiwan and Hong Kong, for example. So much of the data are different for that reason.
What I meant by diagnostic differences, for example, in Poland, you cannot get diagnosed with ADHD in the public sector. So you have to go privately. It's virtually impossible. So look, those people will have to pay a few $100s to get a diagnosis.
Right.
That will not be available to everyone. Certainly, this will affect the group of people who have the.
Yes, the healthcare systems make a huge difference. There's no question about that. Absolutely. That's probably the biggest problem in doing comparisons. Yes, absolutely.
Yeah. So that's what I meant.
I mean, there are some places, I think in France, it used to be you had to be diagnosed by a specialist. You couldn't get diagnosed by anybody else. And typically specialists work in hospitals, so you had to be, find a way to get to Paris or a big city to see a specialist. And so that also changes the diagnostic makeup of the group.
Yeah. Let's go to the fifth study, comparative efficacy and acceptability of pharmacological, psychological, and neurostimulatory interventions for ADHD in adults, published in Lancet. Very important study showing this year, from January of this year, 2025. So once again, this study shows that the ADHD medication is efficacious, but there are some differences. So in my opinion, looking at the results, I would say that medication does not seem to be very efficacious. So I think that the effect was modest of pharmacological treatment, and very often in the clinic, the effect is really strong. What do you think? Why?
I don't know that that's correct. I would say they certainly found significant effects of ADHD medications, both methylphenidate, tamoxifen, viloxazine, amphetamines, alpha-2 agonists. They looked at all of the different stimulant and non-stimulant medications. So I wouldn't say that they conclude that the medications weren't efficacious. I mean, they certainly showed efficacy.
They were, but modest. I say that it's modest, not so strong as we sometimes at least see in the clinic.
Well, that's okay. There's a different question there as to whether what's seen in the clinic differs from what's seen in research protocols. Absolutely right. In fact, we showed in a study I did with that same Swedish group, and interestingly, we showed that in clinical trials. Well, we showed that if you looked at all the population of Sweden, people with ADHD, approximately a third of children and adolescents would be excluded from clinical trials, and about half of adults would be excluded from clinical trials because of their psychiatric comorbidities or other features of them. So people that are seen in the clinic are, yes, they're very different. I want to point your audience to a very important website that came out of that paper, and it's led by Dr. Cortese, who was the head of that paper. It's called EBI-ADHD. And if you go to that website and you click on the Treatment Explorer, you can actually see all of the efficacies of all the different treatments that are in the paper that Jarek is here referring to. It's a wonderful website, easy to navigate, wonderful way to compare therapies.
Now, about the therapy or different therapeutic effects or modalities that we can use in ADHD, what do you think is we know that CBT is standard therapy for ADHD, but do you think there's any new things that we can find in those studies? Because this study explored also DBT, let's say, or mindfulness, or I think relaxation techniques, therapy. So what do you think might happen in the future?
So basically what the study found is what we've known for a while now, is that the only therapies that were efficacious for ADHD symptoms were the medications for ADHD and cognitive behavior therapy for ADHD. Now, the cognitive behavior therapy data are interesting. Well, if you look at what's usually what's recommended, okay, now that's we don't have, there are not a lot of we don't have guidelines yet in the United States about treating ADHD in adults. We do have it for children, right? So for children, we know that what we call parent-mediated behavioral training, that means teaching the parents about how to deal with their children, can be a useful adjunct treatment for ADHD. And there's some evidence that by itself, it's modestly can help kids with ADHD, especially with symptoms of kind of the oppositional symptoms they might have, misbehavior symptoms, let's call it that. The audience would understand that. So, but on their own, cognitive behavior therapy and parent training are usually not that useful. And for example, for children, the parent training is only recommended for very young children, say under the ages of 6. For older children, the recommendation is to start with the medication, and then you add the parent training as needed, depending upon the results of the medication treatment.
You're talking about MTA study, right?
Well, I'm talking about the guidelines now. So what guidelines from, for example, the NICE guidelines from the UK, or the American Academy of Child and Adolescent Psychiatry, the American Association of Pediatricians, they all have these. They're very similar in making these types of recommendations. So that's based upon the differential efficacy of these different approaches to treatment. But I guess to get back to your other question, there have been lots of things that are studied, right? So mindfulness is a good example. There's a lot of new treatments coming out, like transcranial magnetic brain stimulation. People are trying. So far, not effective for ADHD. Neurofeedback has been tried. Neurofeedback so far not effective for ADHD. Acupuncture, different kinds of diet, different kinds of exercise. Now, having a good diet and exercising are good for everybody for all sorts of reasons, but they don't actually reduce the symptoms of ADHD and shouldn't be used as a treatment for ADHD. We do find that many, it's not unusual for a parent of a child to look on the internet, how can I help my child? And you'll get lots of bad advice. Take these vitamins, exercise, do neurofeedback. Go to this website, EBI-ADHD, and .org. I'm sorry, it's not .com.org, and you will find the best current data on these treatments.
That was kind of a trick question on my part, because I asked about DBT, because in my opinion, emotional dysregulation, which is unfortunately still not part of ADHD, is very important. And that's what I was referring to, that in my humble opinion, DBT should become more important part of ADHD treatment or therapy rather. And I hope in the future we will see development of DBT specifically for, I mean, there are some programs specifically for ADHD, but still, in my opinion, they are not well developed. And in the future, I hope we will go in the direction of merging DBT and CBT, because this will, in my opinion, respond better to what the real problems that patients face.
Yeah, you're making a very good point here, and the way I like to describe this is that you can think of two parts of ADHD treatment. There's first treatment of ADHD itself, the symptoms of ADHD, and that's what this paper by Ospinelli et al. Is about. It's about treating the symptoms of ADHD, meaning hyperactivity, impulsivity, and inattention. And yet, as you know, emotional dysregulation is common in ADHD. Other types of executive dysfunction are common in ADHD. And the medications don't do actually a very good job in treating all these symptoms. We know that for sure. I mean, there have been studies of these other types of symptoms. And because of that, it's important that the patient talk to their clinician as to what else is available to help me with the other problems that I have. And DBT certainly is known to be effective for all sorts of reasons, and for certain patients, it's going to be very effective. Other people will benefit from CBT, et cetera. So yeah, really important to kind of talk with one's clinician about what. I like to think of it this way: that after one treats the core symptoms of ADHD, inattention, hyperactivity, impulsivity, what's left over that's not right in the person's life? What can we do to optimize the outcome of that person? And that's where other techniques from psychiatry and psychology become really important.
Yeah. So let me once again say that, in my opinion, each patient is different, and we should always adapt what we offer, the treatment, meaning psychotherapy or neurofeedback or medication, to the given patient. And this is what we are both talking about here.
That's exactly right. Exactly right.
Stephen, thank you very much for meeting with us. I hope this will not be the last time that we meet and talk about new studies in ADHD. Thank you for now, and see you.
Well, thank you very much for having me here, and thanks for communicating to the world about ADHD. It's very important that we educate the public and patients about this problem.
Let me remind you about Stephen's pages. So that's ADHDevidence.org, right?
Yes.
And what was the other one?
ADHDinadults.com.
.com.
Yes.
Thank you very much once again. Bye.
You're welcome.